Good afternoon. It's lovely to have you all here to this live stream session when we're going to be talking about diabetes. My name's Linda de Caestecker, and until recently I was a Director of Public Health here in the west of Scotland in Greater Glasgow and Clyde. And so the prevention of diabetes and the management of diabetes has been very important to me in terms of public health and improving the health of the public. Today is the 14th of November, as you well know, and as well as being the King's birthday, it is World Diabetes Day. The theme of World Diabetes Day this year is education to protect tomorrow. By understanding diabetes, that is the first step to managing it and preventing it. And so much of the management of diabetes is by the person themselves who is experiencing diabetes. And so it's very appropriate that that is the theme, and that's what we're going to be talking about. We're going to look at both type 1 and type 2 diabetes, but particularly around type 2 diabetes, we're going to look at the reduction of risk factors as well as prevention and even reversal. It's been said that type 2 diabetes is a global epidemic now, having doubled in its rates in the last 10 years, in the last decade, and continuing to increase. We did a poll of the people who are using Goldster in advance of this session, and thank you to the nearly 280 people who responded. And it did seem that you know quite a lot about diabetes, particularly around type 2 diabetes, that you do understand that lifestyle, healthy diet, being physically active, as well as not smoking and not drinking too much alcohol are all very important factors in the prevention and management of type 2 diabetes. Of the people that responded, 47 of you actually had type 2 diabetes, and I hope in this session you'll share your experience with us and be very willing to ask questions of our experts here. And 22 of you had type 1 diabetes, and we have Ruth with us today, who's going to talk about her own experience of managing type 1 diabetes in the workplace as well as in her very active personal life. It was interesting as well that in that poll, 22 of you said you'd experienced type 2 diabetes but reversed it. So that's a really encouraging number that, again, I hope you'll share that experience. So I'm going to pass on now to and Zoe will introduce herself as well, to the first member of the panel who's going to say a few words. I'll get everyone to say something, and then there'll be the chance for lots of questions, answers and discussion. But Zoe has been a geriatrician in the NHS for many, many years, so has a long experience of diagnosing and managing diabetes. And she's now the medical director, or the Wellbeing Director, a much better term, at a new retirement community, Riverstone in central London. She's also been a media star, having been part of the Channel 4 programme on old people's homes for 4-year-olds, a great title, and it's about that importance of intergenerational relationships as we grow older. So Zoe, I'm going to ask you to just say a few words on what diabetes is and the differences between type 1 and type 2 diabetes.
Lovely, thanks Linda, and hi everybody, it's great to be here again this afternoon. So as Linda said, I worked as a geriatrician in the NHS, so 21 years I was doing clinical medicine and looking after predominantly older people, but on my on-call days it would be much younger people as well, so all of the different types that there are of diabetes. There are two main types, and that's what we're going to touch on today, but as with so many things in science, all of the things that seem to be very, very black and white often turn into being a little bit blurry. And with diabetes, that can also happen because people go, oh, what about insulin? So what diabetes is, because some people don't even really understand that, all diabetes is a condition where your body doesn't regulate its blood sugar levels. So we take in sugar, and I'm using that in the broadest sense of the term, so that's through carbohydrates as well as the stuff that we all recognise as sugar. And then our body does all sorts of amazing things with that, but it has to regulate what's getting to where. So we have insulin in our bodies that make sure that our blood sugar levels run where they need to be, that they're nice and stable. Then that means our brains have enough glucose going to them, it means our heart, so it means everything works as it should do. In diabetes, things go a little bit haywire. So it might be that your body stops producing insulin altogether. And that's what we call type 1 diabetes, and that's what Ruth's going to talk a little bit about. And the only way that you can manage type 1 diabetes is with insulin. There's no other way to it. You absolutely have to get insulin into your body in some way. And I'm sure Ruth will tell us a little bit more about that. Type 2 diabetes is the one that is more common in older people. Now, we used to think type 1 diabetes only ever started in young people and type 2 diabetes only ever started in older people. But we now know that's not true. Some of that is because of the changes in our society with a lot more obesity and unhealthiness at younger ages, but we're also seeing differences in when type 1 diabetes can start. So in type 2 diabetes, there can be two things happening. So you might not be producing quite enough insulin, but it's not in the same way as in type 1 where there's a complete stop to it. Or the other thing that happens is that your cells don't respond to the insulin in the way that they used to. And when that's happening, that's why you might have tablets to control your diabetes. That's what the tablets are for, to try and help that situation. So to try and make the body make the most of the insulin that it's actually got. The problem with diabetes is you can't ignore it. It is not going to go away. It's not one of those things where, oh, if I ignore it, I'll get better. If you've got it and you don't do anything, you won't get better. And why do doctors get so worried about people controlling their diabetes? Well, so high blood sugars, having too much sugar in your bloodstream in itself causes problems. It makes you more likely to have infections. It might affect the way your brain's working, all of those bits and pieces. But it then affects, we call it end organ damage, which is the terrible doctor way of talking about it, but it's actually quite a good description. So people can lose their sight, vision can be really badly affected, and that's why many people who live with diabetes have to have regular eye tests and actually have somebody look inside your eyes. Kidneys. Our kidneys are essential, and diabetes, especially poorly controlled diabetes, can have a really negative effect on the kidneys. It affects our nerves and sensations, so your nerves in your feet might not work as well, so you won't be able to feel what you're walking on. You can get cuts. If you don't see a chiropodist or podiatrist, you can get real problems with your feet. That can actually lead to amputations. And adding into that, difficulties in the blood circulation, again, as a result of having high blood sugars, so not enough blood going to your legs, increases the chance of heart attacks, strokes, and that's all to do with the way diabetes affects the blood vessels. So it's not good, but the good news is by looking after yourself well with diabetes, actually you can prevent a lot of these changes. Type 1 diabetes develops quickly. So if somebody is going to develop type 1 diabetes days to a week, it's like what we call an acute illness. It comes on really suddenly. But with type 2 diabetes, there are warnings. So a lifestyle that means you're more likely to develop type 2 diabetes, and I know Muir's going to talk a lot about that. And also often what people will have been picked up as having slightly high blood sugars for quite some time. Elevated, not needing diabetes treatment, but that's a real warning, and is where some real changes can be made. There is also a very sneaky blood test that doctors can do that doesn't just measure your blood sugar as it is at the moment. We can look back and see how it's been for months previously as well. That's a really good guide as well to whether somebody's got good blood sugar control or not so good. As Linda's already mentioned, as well as medicines for diabetes, it's actually about healthy diet, healthy weight. And I'm going to stop talking there because I don't want to tread on Muir's toes too much.
Thank you. That was a really great introductory explanation of what diabetes is. Before I come back to Ruth, I'm going to introduce Professor Sir Muir Gray, who, like me, is a public health doctor, and like me, he graduated at the University of Glasgow. We produced some fantastic people, don't we, Muir? And I didn't work with Muir when we were both in mainstream public health, but I certainly knew all about him because he was a very influential figure in the whole screening world, as well as in health information and value in healthcare. So, Muir, can I pass on to you for you to say a bit more about prevention and risk factors and how we might manage them? Muir?
Yes, can you hear me now?
I can.
Yeah.
Thank you.
Yeah, so I've been, Zoe's been many years. I've been many years in the health service. And I'm very experienced. And Oscar Wilde said, "His experience is the name you give to your mistakes." So I'm a very experienced public health professional. And we have to really rethink completely about the future. We can't go on. It's been wonderful, the health service, for the last 50 years. Transplantation, chemotherapy, MRI. But we need to take a new approach. We need to carry on with high tech. We need to carry on with prevention. But we in Goldster are thinking about a new way of doing things, and it's great to have people here on board. I don't actually like the word retirement. We're banning it. We're calling it renaissance. And I think you should be, I know there's a company called Renaissance Housing, Zoe, but it's very good to promote the idea of renaissance, and I know you're doing that. And I did say in the early stage of the development, there should be an office for starting new businesses. And we want older people to be starting businesses and doing things and taking up charity. And I don't actually like the word lifestyle either, because it's an environmental problem. It's the car, the computer, and the desk job. And genetically, we haven't evolved to live in the world we live in, sitting all the time with calories everywhere you turn. And genetically, we're not made for that. And the very eminent professor of biology in Harvard calls type 2 diabetes a mismatch disease, a mismatch between our genes and our environment. I also know a fair bit about type 1 because my younger daughter got it at the age of the early teens, and it's a hellish disease, really. I think there's no other disease you've got to think about almost every hour. So that's type 1, so I know a bit about that. But what I'm going to speak about, and I might just, Linda, I think if Ruth introduces herself, then I'll give a bit of an introduction to the Goldster philosophy, shall I? Maybe shall we hear from Ruth first, and then I'll say open up discussion. Ruth, over to you.
Thank you.
Yeah,
Thank you. Can you hear me okay? Yeah.
we can. So thank you, Ruth, for joining us, and it'd be great to hear about your experience.
So, yeah, I'm diabetic. I was diagnosed when I was 10 years old, but I'm also a nurse. So before I was working with Zoe at Riverstone, I was working in A&E, and now my role in Riverstone is as a Wellbeing Ambassador, which is a great title, I feel. So I feel like Mia said, it is a literal roller coaster of highs and lows having diabetes. And when people ask me what's it like, I kind of say there's never a day off. So you're always waking up, you're always checking. You have to think about your food, you have to think about your hormones, you have to think about exercise. So it's always ticking away in the background. However, I do feel quite lucky because I live in a place with free healthcare, and technology has come on leaps and bounds. So when I was diagnosed, I don't know, my mum's a nurse, so she sent me to school with undiagnosed type 1 diabetes, typical medical professional. I had the thirsty, thin and tired, which is the three kind of how you diagnose type 1. And like Zoe said, it was very acute. I was in a school play, Midsummer Night's Dream, and I kept missing my parts because I was always at the water fountain or having a wee, and then I got in trouble. But since then, when I was diagnosed, I was on 2 injections a day, pricking my fingers very often. I hated it as a child. And then the injections increased and I got the insulin pump. So I now wear an insulin pump 24/7, and that's how it works, similar to a pancreas. So it's much better than, I feel, different people manage it differently, but I feel it's much better than having injections. I've also now got the continuous glucose monitor, so I can use my phone and just it will give me an alert if my blood sugar goes low or high, and I can swipe it and get to know my blood sugar instantly. I don't have to wash my hands and prick my fingers, so it's really good for living a life that's busy. I think in my role as a nurse, it's helped me to be a patient because I can understand what it feels like, and I feel that people open up to me more. And I don't know whether that's because they can see I've got a pump, I've got the monitor now. The residents here, they know me well, so they know I'm diabetic, so it opens those conversations, and I feel it leads to more information sharing. So it really helps if I can use it as my superpower. That's what I like to do. Recently somebody had a tooth infection, and I could say, like, oh, I'm type 1 diabetic, I've had loads of tooth infections, isn't it awful? And you've got that empathy that really builds connection. So I feel like I use it to help me in my role in that way. And then also my dad's got type 1, so I know what it's like to love somebody who's got a chronic illness and is so frustrating. He likes to have hypos at all of the wrong moments. So I've grown up with that, and I think that's also part of my luck. My mum was a nurse and my dad's got type 1, so I had really brilliant role models. So yeah, that's just a bit about me.
That's great, thank you. And did you find it helpful to talk to other people? I know you say your dad's got type 1 diabetes, but other people your own age, and how are you managing it, or what do you do at school or in the workplace?
So there's not many people with type 1 is what I found, but I have got 2 friends who are similar age to me who do have it, and that's where I feel that I'm lucky that I've had my upbringing, because they didn't have parents that were medical professionals or type 1 diabetes in their family, and they have suffered from it. So I've got friends that have got problems with their sight at the age of 30, or a bit of what Zoe was talking about with the feelings in their limbs because it was poorly controlled when they were younger, or they're still struggling to get tight control. So I think if you don't have that privileged starting point, it can be really difficult.
Yeah, so the importance of that control. Muir, I'll come back to you for you to continue with what you were going to talk about.
So let me try and, yep, can you hear me? I'm back in. Okay, I'm going to try and just show a couple of pictures. Let me see if this works in the famous way. Oh, here we are, share. Thank goodness I've got Marcia with me. Okay. Now then. Can you see a picture?
I don't see one, but I don't know, Zoe or Ruth, are you seeing anything? You might need to just describe the picture to us, Muir.
Well, the picture is Captain Bligh being cast off the Bounty on a small boat. And what we see in the health service is that people are very well looked after by the NHS in the, let me just try one.
I think we can see your screen now.
Okay, let me just try.
Yeah, we can see that picture now.
Okay, good. Well,
Yeah,
the health services, the NHS is very good at the acute phase of disease. But after that's over, we felt that we were floating in a little boat until the next outpatient appointment. And remember, people are on their own 99.95% of waking hours if they've got heart disease like me, or type 1 or type 2. I'd just like to comment on some of the things that we're keen to promote in Goldster. And one of them is focusing not only on helping people, I don't like the word patients either, Ruth, people with a condition, helping them, but also, interestingly, what people can do to help one another. So here's a very interesting website. I don't know if you've ever seen this. And this chap, Tom, is Swiss. And this is a terrific comparison of Freestyle Libre against Detcom. So he stuck both things on him, and he really knows what he's talking about because he's got type 1 diabetes. And one of the problems is if you've got a condition like this, is that the not primary care can never get the right level of knowledge. And even in a hospital clinic, it may be that many of the people in the hospital clinic don't really understand the details. So we have to get people helping one another. So here's the sort of conversation that takes place, linked to Tom's site. And people are really giving good advice to one another. Another example of this is my younger daughter, who's not able to be with us today, but she's a member of a network in South London, and there's about 40 odd people in this, of which 27 are in this WhatsApp group. And interestingly, this network is partly about how do you cope with high intensity exercise, but it's also how do you manage the NHS. So here's a discussion taking place about someone who wants to switch to Libre 3. So this is thinking about how do you actually control the NHS. So it's great. And I said to my daughter, well, what do you call your group? And so we feel we're comrades. Comrades are people who have to band together to succeed and look after one another. So this question went up, and and this is someone else, and this is the person. Their reading of the guidance was this. So this is what he's going to say. Here's another example from this WhatsApp group. So here are people now starting to really get a grip not only of how they manage type 1, but how they manage the NHS, which thinks it's managing them. So that's enough from me. If I just stop sharing, I think I'm on Chrome, am I, at the moment? And somewhere there'll be a stop sharing. That's it.
Right. Thank you. That was really helpful and such an important point that it's about managing the NHS. Sorry, Mayor.
And there's someone, Philip, I don't know if you're with us, Philip. Someone I know called Philip, and his experience with his glucose meter was, well, he'd been to the outpatient clinic, but you try phoning the outpatient clinic, and his practice nurse and GP didn't know anything about glucose meters. So, Philip, if you're there, please come in and see us. But his problem was solved by another person with type 2 diabetes, not by the NHS. So what we want to do in Goldster, not just for diabetes, type 1 and type 2, but for every common condition, is build the power. So people really know what is of high value to them, and they can help one another with this. So that's the background of what we're trying to do in Goldster. And I think type 1 and type 2 are really good examples of this, because they're, Ruth, the management of you say, oh, I've got a pump and I've got my phone and everything, but it's bloody complicated. And I wouldn't expect anyone in a clinic, apart from maybe one or two people, and I work with someone who's a diabetologist in South London, but he's got type 1. So he's one of the few people who really, really understands what's going on. So it's that's the future. It's helping people with type 2 and type 1 adapt to the environment, and for type 2 they can reverse it. But it won't just be the NHS who does that. And it's not just you and your own out there as a lonely person in a small boat. We need to get people together, supporting and helping and educating one another.
Thank you.
Philip, if you're there, Philip Briscoe, please make contact with us. And I'm not sure how you dial in on Google Zoom, but there's plenty of stories about, I'm sure, about people helping one another with the knowledge that's needed. And not from me, Linda. Let's hear what people have got to say.
Yeah, no, I don't see anything yet, questions in the chat that I'm seeing, but it'd be really good if people have got questions or comments, as Muir says, your own experience and how you've managed some of these intricacies of pumps and monitoring, etc. It'd be really good to hear from you. I was just going to ask though about reversal, because that's to think you could actually reverse type 2 diabetes. And I don't know if either Zoe or Muir, you want to come in and say some of the most recent evidence that actually it can be reversed if you lose weight or other such things. Zoe, maybe you want to start?
So I can't come up with all the research. Muir is the list the papers man. But yeah, it's we talk about lifestyle advice, that word that Muir hates, and I actually agree. I always see lifestyle as being somebody else. But it's about doing the things that we know are good for us. And not only are these the things that help reverse type 2 diabetes, they're the same things that have been shown to really actually help people live longer, generally older and happier. So it's the same messages coming through. So it's about being active, or as active as you possibly can be. And it can be terribly demoralising if you've been unwell or got an injury, that you're not moving as much as you'd like to be able to, and you think, oh, I'll never get that back. And, how can I lose weight? The doctor keeps telling me to lose weight, but I can't move because my knees hurt. And it's this sort of vicious cycle. And I think one of the things that Goldster can help with, and sort of the in-house programmes that we have at Riverstone as well, is showing people that actually that cycle can be broken, and it's a little bit and do what you can, and then do a little bit more every single day. So it's that get moving more. Active transport is the buzzword for it, but it's about walking rather than catching the bus or getting in the car or maybe cycling. And I'm always moaning at younger colleagues at Riverstone who've got themselves electric bikes rather than ordinary bikes. But actually, if having an electric bike means you're going to get out and start cycling, an electric bike is absolutely better than no bike at all. So it's those small changes. Diet as well, eating healthy food. Not necessarily... So it's not all about the I must eat a diabetic diet. It's about the what things are good for us. So the whole grains, the pulses, that traditional Mediterranean style diet, we know it's good for us. And a lot of that is the messaging that you have to eat well, Ruth. So it also doesn't mean being miserable. I had a wonderful great auntie, Auntie Glad, who unfortunately died quite a few years ago now. But Auntie Glad had type 2 diabetes. And in the end, she was really insensitive to insulin, so was on tablets and had to give herself insulin injections. And this was on the background of some cognitive impairment, so developing mild dementia and with terrible eyesight. It was an absolute trauma for everybody except for her. And she used to manage her diabetes. I used to call it cake and block. So she'd know when she was going hypo and her sugars were going low, so she'd have a bit of cake. She lived in the middle of the countryside, very active, walking everywhere the whole way through. And actually, not the ideal way to manage your diabetes, but it worked for her. And she managed to stay healthy and active and do the other things she wanted to do. So it's about what's finding right for you. And that's the sort of approach that, if I was in a diabetes clinic, I wouldn't actually be allowed to tell people things like that. But it's not about making your life miserable. Diabetes is a long-term condition. Some people with type 2 will be able to reverse it to some extent. Some people have type 1 diabetes aren't going to be able to reverse it. But it's, life is about living. So how do we get life to work with long-term conditions? And so that, as Ruth said, it's in the back of her head, but it's not there at the front the whole time. And I think that's really important as well, and can just generally help that positive approach.
That's really helpful. And Ruth, you'll be pleased that there's a comment in the chat that says your empathy and kindness shines through, Ruth. So I think it's what Muir was saying, for you to be able to help I'm going to use the word patients, your patients, and they know that you are also dealing with, a long-term illness, must be so helpful for them. And your attitude with that, your positive attitude.
Yeah, I think it just opens the conversation. So when I was in A&E, it was a bit more extreme, because people would come in DKA, or they'd be really feeling like they couldn't manage their diabetes. So it was more of a crisis point. So I could have those conversations that they kind of, they call it the teaching moment, that in A&E, where you've got a golden moment to talk to somebody about, want for a better word, but lifestyle and the way they're managing it. So I felt, people's faces would relax if you kind of said like, oh yeah, you don't want to make it about yourself, but I've also got diabetes.
And I've noticed here, so one of the things we do when with people who've newly moved in with us and come for their introduction to to health and wellbeing, we measure their waist circumference. So measuring your waist circumference, no special kit needed, just a tape measure and something anybody can do at home. And we have a few people whose waist circumferences are a little bit bigger than they should be, and that indicates that they're at risk of developing type 2 diabetes. So Ruth telling them in a nice way that perhaps a little bit of work needed there is so different from me saying it, where I'm just being a bit of a nag, and it's, you know, that skinny doctor telling me to lose weight. Ruth is doing that from a completely different point of view. It's exactly the same message, but it's much more meaningful coming that way.
Well, that leads on nicely to what was going to be my next question. And Muir, maybe you could answer this. Just, is there value in screening for diabetes? Should people be going to their GP and saying, can you check if I've got diabetes? And what should they be asking their GP? Muir, are you still there? Can't see you.
Yes.
Yes.
I just gone from mute. I think it's what we see is the need to plan ahead. And if you're 60, the expectation of life is 30. If you're 70, the expectation of life is a little bit less than 20. But we got to think ahead, and we got to think, how are we going to cope with the environment? So you take someone like me, age 78. I've now been in sitting jobs for nearly 60 years. I was an active young doctor for a year or two, but most of our life is spent sitting down. I think the average GP, poor devil, now walks 2,000 steps a day. They switch the computer on at 7:30. I met one GP who wasn't even allowed to walk to the waiting room to bring patients in because that was wasting time, until he told the practice manager that it helped with the process of diagnosis if he did that, so he managed to get away with it. So, firstly, the simplest measure is weight. And it's perhaps a little bit easier test for men than for women. I don't think men should have a bigger waist size than they had when they were 30. So the measuring tape is probably the simplest way of assessing. For women, I think there are changes take place, usually as a result of more than one pregnancy. So it's maybe unfair that it should be the same dress size as you had when you were 30. But I think that's the most important thing, that if you are taking sizes, trousers 2 inches bigger, a 34 as opposed to a 32 or whatever it is, wherever shop you go to, and if you're a woman and you're 3 dress sizes bigger than you were at 30, then not just for type 2 diabetes, but for high blood pressure and for dementia, you want to get back at least 1 dress size or at least 1 notch on the belt. So that's probably the simplest advice we can give people is weight. I don't know what Zoe thinks about that, but that's my simple advice to the people out there.
Yeah, thank you. I was sitting beside a woman in the hairdresser, and she was saying, I was wondering whether I should just give in and become a size 12 or whatever, go up a dress size. And the woman on the other side said, I thought that too, and now I'm a size 20. So, you're right. You have to think ahead and act on these things early. There's a question now from somebody who says, I have a rare type of diabetes, FPL type 3. It is genetic, and my sister has it too. It's characterised by skinny arms and legs. I'm on a very low fat and sugar diet to compensate. I'm only 7 stone but still inject insulin. I just thought I would spread the word, as it is often not diagnosed. So I wondered, Zoe, do you want to say anything about that?
Well, I know that, so that's doubled what I know about FPL diabetes. But when at the start I alluded to things aren't quite as clear as they once were. So when I was at medical school, there were only 2 types of diabetes, and it was type 1 when you were young and type 2 when you were older. And there are now these other rarer types of diabetes being diagnosed. And I think we'll see more and more subgroups come through, particularly with the older people developing type 1. So yes, there absolutely are all of these other forms out there. So thank you so much. I didn't catch the name of the person that's put that comment on, but really spreading that word is so important, because it makes conditions seem more relatable almost. I think one of the things that, and I'm sure it's sort of a failing of the human race, we like to other. So we like to think, oh, that will never be us, that will never apply to us. And I've seen this, particularly in the work I've done with younger people living with dementia. It's when you know that there are different forms that can affect different types of people, you can actually see, well, this might affect me one day, and actually this is important to me. So it's getting that message out there without making people panic or sort of think, oh, have I got that as well? But no, thank you for sharing. And I was one of those doctors who always loved it when a patient came in with a rare disease and could tell me all about it and educate me, because the people who understand their conditions best are those living with them.
Thank you. I'm not seeing the names of people that are putting questions in, so I'm sorry I can't call you by name. But please just come if there's questions that you have or experience you want to share. We'd love to hear about them. But in the absence of that, I'm going to be able to keep asking the questions, which is great. I was just going to ask any of the three of you, what are the kind of most promising new advances that we might be seeing? I mean, we hear about transplants, and I had a friend who had diabetes all her life and then got both a kidney and a pancreatic transplant at the age of in her 60s. She no longer had type 1 diabetes. So some of these new advances, what are the ones we should be hopeful of and look out for?
Well, I'm going to have to duck out of that one, Linda, because not practicing quite so clinically anymore. But I think Ruth knows a few bits.
So the insulin pump at the moment, the person with diabetes has to input what they've, normally with most of them, input what you've eaten in order to have extra insulin with every meal. And then the glucose monitor would be separate. And I think it's Dexcom now coming up with something where they can speak to each other. So before they didn't really want the technology to speak to each other because of the risk of hypos and the machines kind of giving too much insulin, which could be a big risk. Whereas now you can put into the pump an amount of insulin that you would want to have, and then it would titrate it depending on what your blood sugar does. So that's something that's interesting that's coming out at the moment. But I'm not sure of I don't know much about transplants. I have a friend who did have a transplant, but unfortunately it was unsuccessful, which I think with pancreases is quite common.
Yeah, so a lot of the important advances are about how we administer insulin and improve control as you've described. I want to come back to something you said, Muir, about it's not just managing your diabetes, it's managing the NHS. And, your point that the patient, I know I'm still using the word patient, but, that they are the experts. But what kind of advice can we give people in how to get the best out the NHS when they've got a disease such as diabetes?
Well, for me, the big change, we're now in the third healthcare revolution. The first healthcare revolution was the public health revolution. It gave us clean, clear water. The second revolution was the high-tech revolution, in which big bureaucracies like drug companies and hospitals gave us high-tech medicine, which is fantastic. I mean, insulin was the early 100 years of insulin, but most of these things have been the last 50 years. But the third revolution is driven by three forces: citizens, knowledge, and the internet. This is far more important than the human genome. And I see two things happening. One is we're now able to type 1 and type 2, instead of a whole lot of little islands, health centres and hospital clinics and labs. And secondly, the sort of thing we're talking about now is people connecting with one another. Now, the issue is, what is the role of the health service, the NHS, and it's very important. They've got lab scientists and they employ doctors and nurses. But actually, we now know that for a long-term condition, as I said, people are on their own 99.95% of waking hours. So I've got heart disease, and I see the health service about an hour a year. And there are I think, 5,840 hours when you're awake in the year. So it's not a very high proportion. So we now need to assume that we are responsible. Only the person called the patient is constant. Everyone else is part-time, shift work, whatever. So I think that my advice to people with any long-term condition is to get it all on here. All the drugs you're taking, the doses, who your contact points are, what your health is, it has to be there. And then I think we should help people prepare much more for going to see the hospital. Take another example, elective surgery. People rock up to a clinic the first time in their life they've ever had a discussion about having their hip replacement. The doctor's done it 1,000 times. The person who goes to hospital is so anxious that we know no matter, and this is very intelligent people too, they cannot even remember if they asked all the questions they want. So I think we should be sending information to people called patients and asking them, what's really bothering you? What have you tried? What are you most worried about? Could you please write it down and send it in? Now, of course, there are still many people not on this, but that number is decreasing among older people. And I saw as they laid the wreath yesterday for the veterans charity is now helping veterans get online. Young soldiers are helping older soldiers get online. So I think now we in the health set, the NHS, need to recognise that simply sending people a letter telling them to turn up at 2 o'clock on the 14th of November is not the best use of their time or your time. And for the people we call patients, they need to think, well, the health service is pretty disorganised, so I better get organised and be ready and be clear about what's bothering me most, what questions I want answered. But I may find this is the mission of the Goldster Health Service, the GHS we call it, not the NHS. Our mission is to really accelerate and develop people working together to support and help one another. Both are very important, but the one we've ignored has been self-care and care from the people my daughter calls comrades, other people with type 1.
Yeah, it's such an important point. And it leads well on to another comment that's been made where someone's saying, my husband has just been diagnosed on the borderline of type 2. He's been watching his diet, which is good, and exercising, but has not had any further contact from the doctor's surgery to recheck his blood sugar levels. Is this important?
Shall I come in with that one?
Yeah, that'd be great.
So it's Joan. I can see it on Facebook as well. So
you can see it.
So thanks, Joan, for asking that question. So at the start, I mentioned there's a blood test that tells us how blood sugar control has been over the past 3 months. So that is most likely the test that your husband had. He may have had a finger prick one, and that may have led on to the practice doing the other blood test. So yes, in due course, he will need it checking again, but not too quickly, because actually it wouldn't produce, we wouldn't be able to see the changes. So probably around 6 months' time, it'll be worth getting that rechecked. And that's often something that the practice nurse will do. So he might not need to see one of the GPs. He may well just need to book in with the practice nurse to have that done. But the other thing to know is to be aware of the fact that he knows he's borderline diabetes. So Ruth mentioned the whole, getting thirsty and weeing a lot. So those are the things that I'd also say to look out for. If he finds he's drinking loads and loads and loads, and then also weeing lots of that fluid out again, that's a sign that blood sugars in the bloodstream are high. It's all to do with osmosis. And if that happened, then he'd need that blood sugar checking much, much quicker. But yes, 6 months or so, and then worth checking again, so that next time he goes back, he'll really be able to see the efforts of all of his hard work as well. But yeah, just know on that thirstiness and the weeing a lot as the things to look out for.
Great, and that's reassuring then, hopefully, that it hasn't been 6 months, but that's when you should be looking for another check. Thanks for that answer. I wonder if I don't see any other questions at the moment. I wonder if we should go back and we've talked about weight and diet. I wonder if we should say a bit more about physical activity and how important that can be also in reducing risk and also in managing our weight. Muir, what advice would you give to somebody like me, 65, want to keep as active as I've always been? How do I manage to do that when, as you say, the tendency is we're so sedentary and we sit in front of a screen all the time? What's your best advice?
Well, the physical activity is often also, we always think of activity, physical, cognitive and emotional. So we need to think about all three aspects of activity. And the evidence is that there is an effect of aging, and aging reduces your resilience. So every year you've got to become more active. So at 65, you need to become more active than you were at 64. And if we just take the physical, I find it helpful to think of there are 5 aspects of physical fitness, all beginning with the letter S: strength, stamina, suppleness, skill, and the 5th S is, Zoe? Psychological. Pathetic, but there we are. So stamina, 30 minutes brisk walking, and I'd recommend there's a program called EXI that you can get exercise, but this is the NHS brisk walking app. So I've done 70 minutes brisk walking today, and I intend to do 32. Next year, if I survive, I'll do 33. So obsessional walking, and then not so much for diabetes, but suppleness, skill, and strength. Then a daily dozen, 12 minutes a day of strength, suppleness, and skill. And yoga, Pilates. We're planning to make recommendations through the NHS, but if they don't do it, we'll do it through the GHS for Pilates, yoga. It doesn't matter what we do. For skill, I've got a very good technique for skill, and my wife was a bit concerned when she first heard someone say, a young woman say, I think of Dr. Muirgray is going to speak, and I think when I'm getting ready for bed. And the reason is that I'm very keen on people standing on one leg when they brush their teeth, because the toothbrush has got a 2-minute alarm on it. So there are a number of people thinking of me as they get ready for bed, but no more than the fact that they should be switching the toothbrush on. So for diabetes, the main thing is stamina, and that brisk walking is sufficient. I am very much in favour of cycling, and I live, of course, in Oxford, a cycling city, and I'm very much in favour of e-cycling. And I think in 10 years' time, it's only going to be young, keen people like Margaret McCarthy on an ordinary bike cycling up the hills near Glasgow. That the new single-wheel e-bikes are a great breakthrough. So I think we need to get 500,000 people back in bikes.
I agree with you. I think they're great. And hopefully they'll come down in price and it'll stop us using our cars. So I'm all for it.
Have a look at the new...
I've lost you. Have you gone on mute? Oh well.
Yeah, have a look at Switch, SWYTCH. You just get a new front wheel and stick the front wheel in on your existing bike, which is much lighter actually than the usual electric bike. That's when the revolution is taking place.
And if you want to cycle in the beautiful Highlands of Scotland and see the most magnificent scenery of your life, there's a lot of hills there, and an electric bike makes all the difference.
Yes.
Now, I was going to come back to something and I've forgotten what it was. Just see if there's any other comments from the audience. Just in terms of if you're going to get a checkup from your doctor, from your GP, would you expect them to check your sugar or your glucose in any way, Zoe, and should we be asking for that?
So they wouldn't be checking unless there's a reason to check it. However, there is a screening programme at the moment for diabetes. And the reason I found out about this, so my mum is over 70. She'd get gold stars from Muir. She is the same size as she was when she was 18. She gardens profusely, I think is the only way. She briskly walks the dog. You know, all of those boxes are ticked. So mum and her group of friends, all really quite similar to her, were all quite cross that they were coming up as moderate risk of diabetes. So this is why I looked into it to find out that there was a screening programme taking place. And then Ruth and I looked it up because we thought, do we want to do the same thing here? And our answer was no, because screening programmes have to be appropriately sensitive. And in this one, you get awarded 12 points for being over the age of 70, meaning that everybody aged over 70 is coming up as moderate risk of diabetes and then going on to have further tests. So there's a chance that a lot of people on this call and a lot of people within Goldster's catchment might be sort of picked up as part of that screening anyway. It is the sort of thing, though, I would expect if somebody's got symptoms of type 2 diabetes. So I've talked about the thirst and those direct issues of having that high blood sugar circulating. We've talked about infections. So if somebody's getting too many infections, you think, why? And looking at somebody's sugar then would be routine. It should be done on every single person going into a hospital. It is a standard screen at hospital because you're going to pick up more positive results then. So it's a benefit to do it then. So if you go to hospital, they should be checking it there. And yeah, it's one of those things if there's a reason to do it. And sometimes, lastly, if you have your urine dipped for anything, so again, that could be just a routine appointment, and they say, oh, bring a sample along with you. One of the things on that urine dipstick is glucose, and you should never have any sugar in your wee. So if your doctor or a healthcare professional has picked up is that positive on a urine dipstick, they then also may go on and test you for diabetes. So not everybody, but there's a lot of ways to pick it up appropriately. And we shouldn't screen absolutely everybody turning up at their doctors. That wouldn't be right. We'd get a lot of false negatives, which in themselves can cause harm and distress. But I think the approaches being taken at the moment really are right.
Yeah, I couldn't agree with you more. We've got to be very careful that we're screening for the right things and we're not over-medicalising or over-diagnosing. Gita on the chat has asked, Muir, could you give us the name of the NHS app that you showed us?
Yeah, it's called the Active 10, that red one there. Active 10.
Okay.
I was involved in setting it up about 10 years ago, and it's pretty good. It's, I think it's very good. It seems to know when I'm walking briskly. I'm not so sure. Sometimes you got to watch if the phone's in a handbag, so it's in my pocket. But I think it works all right in the handbag too. It's very clever. So the Active 10 NHS app. It's an NHS service.
Great. And people will use all sorts of things. I use a Fitbit, and others will use their Apple Watch or their phone or things. But if that's a free app, and it's good to hear somebody's positive experience of it, and hopefully you'll go and have a look at it. I don't think there's any other questions, but please come in and share your experience again. As I said at the start, the theme of this year's World Diabetes Day is about education. And one of the areas in the World Diabetes Day is education for health professionals, not just for individuals who are experiencing diabetes, although as we've heard, that's probably the most important bit, is that you understand your own disease and you're managing to do self-care as well as see professionals. But Ruth, I don't know, do you feel that the education for health professionals around diabetes is good enough, or is there more that should be done?
I think Yeah, when I was working in the NHS, oh, can you hear me okay? In the NHS, lots of my colleagues used to ask me questions, and I think there still is, unfortunately, not a kind of clear understanding. And I think part of that comes from it being such a that there's lots of different types, and different people have different experiences of it. So yeah, I think from my own view of being somebody with diabetes and somebody working in the health service, I think, yeah, there's a lot more education needed.
And I think actually with the newer bits of kit coming through, so Ruth and I are off to a medical conference later this week and been looking at, so there's some really good sessions on diabetic feet and all of those sort of things. But in terms of the actual technology, and you know which drugs are coming through because you learn about those, but in terms of that applied technology, so again, I used to take the opportunity, if I had a younger diabetic with a piece of kit I wasn't familiar with, that I'd get them to tell me about it and show me how to use it. And I was fortunate because I worked in the accident and emergency and acute medical unit. I had the opportunity to do that. But if you're not seeing people with something regularly, and especially the speed the technology is advancing, because it is so much being driven by people living with diabetes, then actually through no fault of your own, as a medical profession, it can be easy to not be as in date. And this is why well-informed patients are absolutely vital, because you can teach your doctors a thing or two.
Yeah, and I thought what you said earlier, and you said it when it was a rare disease, but even with common conditions, you like when a patient knows about their disease, and we'll talk to you about that. And I guess that's to encourage us not to think, well, I can't tell the doctor, they're the experts. You can, and you should. And as Muir was saying, be prepared, know what questions you want to ask, and be ready to ask them. Well, both Gita and Joan said thank you for the advice you gave. We're coming to the end of our time, and I'm not seeing a lot of other questions, but if you've got one in the last couple of minutes, please put it in the chat. But I would just like to say that's been a really helpful session. I've really enjoyed it. It's wonderful to hear about just the very practical tips of how to be more physically active as we get older, and just the very simple things that we can do, and also to hear more about actual diabetes and what are the things we need to look out for, and how we need to learn from each other as people experiencing chronic conditions, but also how we need to be proactive with our healthcare providers. So Zoe or Ruth, any last remarks before we come to an end? Any pearls of wisdom that you didn't get the chance to say?
I'd just say probably getting a diagnosis of diabetes, it isn't the end of the world, although it might feel like it at the time. And there's the official help out there, and as Muir's really shown us, there's the, that peer support. And yes, it may not seem as devastating as it might do at the time when you get that diagnosis. Things can be done.
Yeah, I think on the back of that, there will be good days, there will be bad days, but the support that is out there is really good as well. So, yeah.
That's really encouraging. Thank you, both of you. Muir, any last comments you want to make as we come to the end of this session?
Yes. Viva la revolution. We're now in a revolution where we're recognizing that self-care and care from comrades with the same problem are at least as important as high-tech clinical care. We need both the NHS and the GHS, the Goldster Health Service, and our mission is to promote the revolution.
Yeah, let's keep that in our mind, especially when everyone's complaining about the NHS and you've got to wait for a long while for an appointment or an operation. Actually, there's so much we can do with, for example, Goldster Health Service and our own interactions with other people and looking after ourselves. So that's a great place to end. And thank you for all the comments, for the questions, and thank you especially to Muir, to Zoe, and to Ruth. I really appreciated your input, so thank you.
And thanks, everyone.
Bye-bye.
Bye.